Hello, my name is sauljweiner. I've been looking forward to putting together this video for some time. For years, my team has been studying a concept called contextualization of care. And during this process, we've developed an audio coding system called Content Coding for Contextualization of Care, or 4C for short. 4C is utilized to determine whether a care plan is contextualized, meaning that it takes into account the life challenges of a particular patient. The video is divided into two parts. First, I'll provide an overview of the concept and introduce some terms, and I'll give some examples. And then I'm going to turn it over to Amy Binns-Calvi, who has been instrumental in developing the 4C coding system, and she's going to demonstrate how one determines whether a care plan is in fact contextualized. So let's get started. I'd like to start with specific definitions of these two terms. Contextualizing care is the process of adapting research evidence to patient life context. It entails answering the question, what is the best next thing for this patient at this time? Conversely, a contextual error occurs when the failure to contextualize care results in a wrong plan to achieve an aim. It's a medical error due to inattention to patient life context. This slide summarizes many years of research on this topic with just a few highlights. First, we found that in about 40% of real ambulatory visits, effective care depends on identifying and addressing patient context. We've also found that in 40% of encounters in which care depends on attention to context, physicians overlook context, meaning there is a contextual error. We found that contextual errors predict worse healthcare outcomes and that they also result in overuse and misuse of medical services with higher costs. In addition, there seems to be wide variability among physicians in terms of their attention to patient life context. We've also found that physicians improve with feedback and their patients in turn have better outcomes. The cost of providing this type of feedback is far outweighed by the benefits in terms of return on investment. Lastly, and this is somewhat of a surprising finding, physicians who do this well during medical encounters do not, on average, have longer visits than physicians who overlook context and make contextual errors. Contextualizing care is a four-step process. The first step is recognizing clues that a patient may be struggling with a life issue. We call that a contextual red flag. It's a clue that something in a patient's life situation might be impacting their care. The second is asking about that contextual red flag. We call that contextual probing. It's an attempt to inquire about a contextual red flag to find out what in the patient's life situation might be impacting their care. The third is identifying when present a contextual factor, and that's anything in a patient's life situation that is in fact impacting their care. And the fourth is establishing a contextual plan of care, a care plan that will take contextual factors into account so that the care will be effective. The first of these contextual red flags come both from the medical record, for instance, a patient missing a lot of appointments or not refilling meds could be a clue, and also from listening to the conversation between the doctor and the patient and hearing comments like, boy, doc, it's been tough since I've lost my job. And the latter three are entirely elicited from overhearing the conversation between the doctor and the patient. And we'll be looking at how that's done in just a moment. So here's an example. Patient with a history of a stroke has missed a lot of appointments in the prior year, mostly to physical therapy. What we hear is the physician asks, why have you been missing so many appointments? And then the patient replies, well, they scheduled my physical therapy appointments at a new location and there isn't a bus that goes there. Only sometimes can I get a ride. And then the physician says, well, looking online, I see that the place you used to go to now has openings again. How about I just reschedule you to go there? And the patient agrees. Contrast that with this scenario in which a patient with a history of stroke has missed a lot of appointments in the prior year, mostly to physical therapy. The physician is distracted and doesn't pick up on that, or perhaps never looked at the section of the medical record to see that the patient had been missing these appointments and doesn't probe. Well, that in and of itself could be the end of it. But in this case, the patient goes on to say, quote, they scheduled my physical therapy appointments at a new location and there isn't a bus that goes there. Only sometimes I could get a ride. Well, that would have been a second opportunity for the physician to act on that information, but the physician didn't. So we end up with a failure to contextualize care. We've sorted contextual factors into 12 broad domains. The 6 on the left are life circumstance issues, and I've highlighted the one at the top to indicate that in the prior example, the patient's inability to get to their physical therapy represented a barrier to access to care. The 6 on the right, in contrast, rather than being life circumstance issues, are really things going on in the patient's head that affect their behavior. Like, for example, number 8 is emotional state. If the patient is depressed, they may just stop going to appointments. And we found that all of the contextual factors that we've identified sort into one or more of these 12 categories. I should also mention that the contextual red flags also sort into various categories. In fact, there are about 70 of those. And this ability to sort and categorize contextual red flags, contextual factors, is actually very useful for looking descriptively at what's going on to a large group of patients. And you'll see that in just a moment. So in this example, we see how a physician almost made an error, but then, thanks to the patient, didn't. So it goes as follows. Red flag. While they're discussing his medications, a patient says about one of them, quote, "I haven't taken those pills in weeks." Well, the physician's distracted and doesn't pick up on that comment and doesn't say anything. But the patient goes on to say, quote, "They changed my medication coverage and I just can't afford them." This time, the physician picks up on the comment and says, "Let me check and see what your insurance plan will cover. My staff will check and get back to you. In the meantime, we have some samples to tide you over for a few days." So here we see how a care plan got contextualized, not because the physician probed, but because the patient went on to reveal the contextual factor, and then the physician did the right thing. So what you can see here is that contextual errors can occur either because of a failure to probe, or if a contextual factor is revealed, a failure to address it in the care plan. The way we collect this data is by handing audio recorders out to patients in the waiting room before their visit. This is done either by volunteers or by a staff person. When the patient comes out of the visit, they return the audio recorder and it is uploaded to a secure server. Then, trained audio coders listen to the recording while also accessing the patient's medical record. The coding system, as I mentioned, is called content coding for contextualization of care. The way it works is that audio coders first look and listen for contextual red flags in the medical record, such as missed appointments, and also listen to the audio for comments like, "I haven't taken those pills in weeks." Then they listen for contextual probes, contextual factors, and contextual plans of care. And then finally, and this is optional, the coder can go back at 4 to 6 months and look and see what happened to the red flag to determine whether there was a favorable outcome. Detailed instructions on how to code in 4C are available at a public site using the link at the bottom. One key concept that I want to mention about how 4C works is the preconceived ideal. This is basically an anchoring technique. So what happens, and let's start with the probe as an example. After hearing a contextual red flag, the coder will write out what they think would be an ideal probe. For instance, "I notice you've missed a lot of appointments to physical therapy. Can you tell me what's happened?" Then the coder will listen to what the actual probe was. In this example, "Why have you been missing so many appointments?" And then the coder will ask themselves, "Is the probe that I heard close enough to the ideal probe to count?" And in this example, yes, it is substantively really the same thing. Compare that to, again, the same ideal probe. The coder writes out, "I notice you've missed a lot of appointments to physical therapy. Can you tell me what's happened?" The probe heard is, "It's important you do all your physical therapy to have the best outcome." Is that close enough to count? No, it's substantively different. And using this anchoring technique, starting with an ideal probe and then listening for the actual probe and then comparing them, has allowed our coders to achieve a very high level of inter-rater agreement. And this general approach is applied not only to contextual probes, but to POCs and to outcomes. This chart just shows you how you can quantify performance of a group of physicians. The blue line represents the percentage of audio recordings in which the care plan was contextualized, and the yellow line is the percentage of audio recordings in which the red flag was probed. And this is a group of physicians who receive continual feedback on the performance, and over time you can see they got better. This shows how the 12 domains that I showed you a few minutes ago can be visualized across a population of patients. Here we've got a group of patients in a clinic, and we see that by far and away the biggest challenge they faced was a skills and abilities deficit that affected their ability to manage their care. So this is a nice way to visualize what a particular population of patients in a clinic is struggling with most. So as we move to the next phase where Amy takes over, imagine that she has her headphones on, that she's listening to an audio recording of a visit, and that she has the patient's chart open. She's going to be extracting contextual red flags from the chart first, and then listening to the audio. You'll also see that she'll use the drop-down menu in RedCap to assign contextual red flags to categories and contextual factors to domains, like barriers to access to care, loss of social support. And this is necessary to generate the kind of analysis that you just saw in the tables. that were in the previous slides. So if you'd like to learn more about Contextualizing Care, go to our website. If you'd like either a free copy of the coding manual or the XML file that Amy uses in REDCap, go to the Dataverse site. And if you want to reach me, I'm accessible at my Gmail. Finally, I want to disclaim that this material is based upon work supported by the Department of Veterans Affairs of the Veterans Health Administration, Office of Research and Development. However, the views expressed in this presentation are those of the author and do not necessarily reflect the position or policy of the Department of Veterans Affairs or the United States government.
Hello, I'm Amy Binns-Calvi, a co-creator of Content Coding for Contextualization of Care, or 4C for short. I also developed this REDCap project to capture the 4C coding. If you have downloaded the manual, many of the examples are given in an Excel format. This tutorial should provide you some guidance if you want to capture your coding in REDCap. In this video, I'm going to be reviewing entering 4C coding into REDCap, but I won't be going over how to set up a project. There are many great online tutorials that go over all the great things that REDCap can do. I'm also not going to be doing a deep dive into 4C itself. Again, you can refer to the 4C manual for all the nuances of 4C coding. If you watched Dr. Sauljweiner's intro, you know that 4C coding is based on chart review and audio recordings. We won't be looking at actual charts or listening to any recordings, but I will talk you through a couple of examples so you can see how to capture the items in REDCap. So if you look on the screen, you can see that I have my project open, and I am going to click Add a New Record. You will see that there are 3 instruments here in REDCap. We are going to be starting with our first instrument, the 4C Encounter Info. And this is the demographics and the info for the actual appointment. So this is being coded by me, Amy Binns-Calvi. The date of the encounter will make it today. The patient ID, we de-identify our data for the patients, so we're going to give our patient the number at 111. Did the patient see the wrong provider? For our example, we're going to say, nope, they saw the correct provider. And then I'm prompted to give also an ID for that provider. We'll just make it 111 for today. Was the recorder revealed? This is an item that I will have to come back to after I have listened to the entire recording. And the reason why we're tracking this is sometimes our patients will show the provider the recorder in their pocket or their purse. And we just want to keep track of that in case that influences the provider's behavior during the visit. The next item is, did the recorder fail? We're going to say, nope. We have a recording. And so now I'm going to save and exit the form. As Dr. Weiner mentioned, the 4C includes looking at in the chart for red flags as well as the audio. So I'm going to go to our next instrument, 4C coding, and I will start off by looking at the patient's chart. So it's a chart coding that I'm doing. As I look at the chart, I'm looking for any indications that there might be something going on in the patient's life impacting their ability to manage their care. And in this case, I did identify a red flag. Looking in the patient's chart, again, the red flag type is a chart, I see that patient missed 10 out of 20 visits for an SAA of 50%. An SAA, once you look at the manual for 4C coding, is what we call scheduled appointment adherence. And in order for us to calculate an SAA, a patient needs to have had at least 16 visits in the past 12 months. When I go down to the next item, you'll see that, as Dr. Weiner had mentioned in the introduction, we have close to 70 red flags that we have categorized from our years of coding, and they fall into these 9 different categories. We have a level of red flag like an SAA that is a high impact red flag, and these are the red flags that are easily quantifiable in order to follow up later on to look for outcomes. But here you will see I have a drop down of these 70 red flags that we have already identified. And we have a catch-all at the end, which would be an other, in case there is something that doesn't neatly fit into one of our categories, but you still think that it's an indication that the patient has something going on in their life. But as I said, I know that this particular red flag, since the patient had an SAA of 50%, that is definitely less than 75%. So we are going to choose that for our red flag. Now that I know what the patient's chart red flag is, I'm going to go ahead and formulate an ideal probe. And in this case, our ideal probe is, I noticed you missed many appointments. What is going on? The reason why we have an ideal probe, as was mentioned in the introduction, is that this is an anchor for me. So when I go to listen to the audio, I will be able to see if there's something that the provider says that is close to my ideal probe. So at this point, I have identified my ideal probe, and I am going to save and exit the form. Now I'm going to be listening to the audio, keeping in mind that I'm listening to see if the provider asks about missed appointments or if the patient reveals a contextual reason for missing those appointments unprompted, or if the patient reveals another red flag. As I'm listening, I hear the patient say, I haven't been taking my pills in weeks. What I would do then is I would pause the audio and I would go down here to add a new red flag. And in this case, it is an audio red flag. Yes, there is a red flag. Yes, it is an audio red flag. And what has happened is that our patient has made the statement, I'm not taking those pills in weeks. And I'm going to go ahead and just copy and paste because I have already typed these in, but I would normally type this in. I haven't taken those pills in weeks. We're going to go to our drop down again. And luckily, the more you code, the easier it gets to identify and remember what these red flags are for their numbers. So in this case, we are looking for missed medications. And here we're going to see the patient is unable or declines to take medications as prescribed. That's going to be the red flag that I pick. Now that I know what the red flag is, now I'm going to identify what I think is an ideal probe. And in this case, my ideal probe would be, why aren't you taking those pills? So I would restart the audio and continue to listen to see if our provider says anything about the pills. As I'm listening, I'm going to save and exit form. And the reason why I'm doing that is because now it's a nice way for me to see what are the two things that I am listening for. So I continue to listen, and our provider does not say anything about the medications that are being missed, but I do hear the provider say something about missing appointments. I would pause the audio, I would open back up this red flag, and I would go down here, and I heard the provider say, why have you been missing so many appointments? So was a probe heard? Yes, it was. What was the probe? Provider said, why have you been missing so many appointments? Was this a contextual probe? Yes. And we're looking to see, are they asking about a patient's context, something about their life circumstances? Is this a close enough probe? Is it close enough to my ideal to count? I'm going to say, yep, it's pretty darn close. And then I'm going to go back and continue to listen to see if the patient reveals a contextual factor. In our case, our patient does reveal a factor. Yes. It was in response to the probe because the provider said, why have you been missing so many appointments? And what I had heard was that the patient said, and I'm going to copy and paste so you don't have to watch me type. The patient said, they scheduled my physical therapy appointments at a new location, and there isn't a bus that goes there. Only sometimes can I get a ride. Now that we know the factor, I'm going to pick the domain that that factor falls into. And again, during the introduction, you saw that Dr. Weiner explained how we had the different domains. In this case, because the patient cannot get to his appointment, we are going to say that is access to care. The next item on my list here, is it possible that this factor is actually patient preference? Sometimes you will hear a factor revealed, and quite often this is something that will primarily be maybe getting a vaccination, and the patient actually just doesn't want to, even though they might say a different reason. And you as a coder might be able to tell that it could possibly be preference. But in this case, we can tell that our patient would like to come to their PT appointments. And so this factor is not patient preference. And now that we have the factor identified, I am going to go ahead and put in here, similarly how I put in the ideal probe, I'm going to put in the ideal outcome for this red flag. And the ideal outcomes are always a resolution of what the red flag was. So if I scroll back up, I can see that the patient had an SAA of 50%. And so our ideal outcome is going to be an SAA greater than 50%. I am also going to put in an ideal plan of care to address this factor. So since this patient is having trouble getting to their location, my ideal plan of care would involve something along the lines of change the location of the PT appointments to one that the patient can get to, or refer the patient to a social worker to identify some workable plan for transportation, such as a van service. I will start the audio back up and listen to see what our provider does. In our example, our provider does a great job and does make a plan of care. And the plan of care that I hear our provider says is, looking online, I can see that the place you used to go to now has openings again. How about we just reschedule you there? Was this a contextual plan of care? Yes, it was. Was it close enough to my ideal to count? Yep, it sure was. Was the plan of care carried out during the visit? No order necessary. Sometimes a plan of care, if it is something like an education, will take place during the visit, and there won't be an order placed in the medical record. This will come into play when we go back and look for outcomes, if that's what you're going to be doing. This will make more sense when we go to the next instrument. But in this case, because our provider said that they were going to put in an order for them to go back to the original physical therapy location, we're going to say that the plan of care was not carried out during the visit. This is an open text box for coder comments. So if I wanted to type something in that I think would be of interest in the future, it could be provider picked up on the red flag right away, or anything that I think would be of interest later on when we're reviewing the codings. Same thing here. There's one more option here. We put together reports based on our coding and we present them to the providers. And sometimes it's very helpful to have a good narrative example to use in a report. This is a pretty great example. So I'm going to click yes. We have now completed everything for this one encounter before somebody goes back to look for outcomes. So I am going to go ahead and say that this one is complete. Now we still have another red flag, so I'm going to save and exit the form so we can go back and remind ourselves we're still listening to see if the issue of medications comes back up. So I will start the recording back up again to see if that red flag is probed or if anything else comes up during the visit. As I'm listening, I do not hear our provider ask about the taking the medications as prescribed. But as our provider is continuing with the encounter, the patient spontaneously reveals a reason for not taking the medications. I would pause the audio, go back here to this red flag. And in this case, I did not hear a probe, but a contextual factor was identified, and it was spontaneously revealed by the patient without a probe. And what I heard was the patient say, yeah, they changed my medication coverage and I just can't afford all of my meds. Again, I would pause because I want to pick what domain is this in. So the patient said, I can't afford my meds. That would be a financial situation. Again, is it possible that this factor is a patient preference? I'm going to say no. Because there is a factor identified, what's the ideal outcome for this red flag? And again, the ideal outcome would be a resolution of our red flag. So since the patient hasn't been able to take their pills, the ideal outcome would be patient is able to take meds as prescribed. What would the ideal plan of care be to address this factor? So we saw that the factor is a financial situation, and that is why the patient can't afford the pills. And so our ideal plan of care would be to check insurance formulary for covered alternative and or a cheaper generic. I would start the audio back up and listen to see what our provider says. In this case, again, we're in good luck. Our provider does make a plan of care. And the plan of care that I hear is that our provider says, let me check and see what your insurance plan will cover. My staff will check and get back to you. In the meantime, we have some samples to tide you over for a few days. Was the plan of care contextual? Yes, it was. Was it close enough to my ideal to count? Yes, it was. Was the plan of care carried out during the visit? No order necessary. Well, our provider said that they might be changing the prescription to see according to what the insurance plan covers. So I'm going to say no, that would require an order to be placed. But I am going to put a little note here to myself to say samples were given during visit, just in case there isn't a cheaper alternative, but we know that this provider did have a contextual plan of care to at least address the issue in the short term. Would you like to designate this to be used as an example for a future report? I'm going to go ahead and say no. And now this is complete. I will save and exit the form. I would go back and continue to listen to the audio in case another audio red flag is revealed. For the sake of our example, I'm going to say that no second audio red flag was revealed. Now what would happen is 4 to 6 months later, a separate coder would come back and look for outcomes. Not everybody needs to look out for outcomes, but if you decide to follow up, it's great data to have. So 4 to 6 months later, a different coder would come and check for outcomes. So they're going to click here on outcomes. And you will see, first you type in the returned visit or date the record was checked for outcomes. We're going to say that this was 4 months after the initial visit. The ideal outcome, and this is pre-populated from what we had in the other form, is that the SAA is greater than 50%. And we're going to say that I, as the outcomes coder, have gone in and looked, and I saw that the SAA now equals 75%. And I'm going to say that is a good outcome. Now that I have identified what the outcome was, I am going to go back and I'm going to look to see if there were orders that needed to be placed and were they placed. And the reason to do that is sometimes the audio coder will hear the provider say that they're going to put in an order and then it doesn't actually get put in. So we want to make sure that we're tracking that, because in case the ideal outcome was poor, we would want to know whether or not that actual plan of care, those orders were actually placed. So as the outcome coder, I'm going to save and exit the form. And then I can see that these outcomes were for red flag 1. I'm going to go back into that coding and I am going to scroll down and I'm looking for 2 things. I am looking to see, was the plan of care carried out during the visit? No order necessary? And I can see no. So there should have been an order necessary. So then I'm going to look at the plan of care. And I can see here that the provider was going to reschedule visits at the physical therapist. So I would look in the medical record and see if that order was placed. I'm going to go back. And for the purposes of our example, we are going to say that the orders for the plan of care were placed. And now I can say that this is complete. And I am going to save and add new instance because I know that there's another red flag. And here we can see there is a second outcome to look for. I am still looking for on the same date, so it's 9/21/21. And this one is the ideal outcome is patient is able to take medications as prescribed. And we'll say again, I look in the medical record and I see in the notes that somebody has written, patient is taking all meds as prescribed. This is again a good outcome for this patient. And we're going to do the same thing we did before. First, I'm going to save and exit the form. I'm going to go to my red flag. I'm going to scroll down and I'm going to see, was the plan of care carried out during the visit? No order necessary? Nope, I need to look for an order. So then I'm going to look up here and see what the order would be. And so it looks like I'm looking for an order to see if new medications were placed that are an order for cheaper medications. So I'm going to save and exit, go back to my outcomes. And in this case, yes, I looked and I saw that the provider was able to order a generic version of those medications. And I am now able to say complete and save and exit the form. Now, if you remember, the great thing about REDCap is that it will give us these color codings when we can say something is complete. In this case, if you remember when we started off, I was unable to complete this because I had to indicate whether or not the recorder was revealed. And for the purposes of our example, the audio coder said, nope, the recorder was not revealed. They kept it hidden throughout. And now I can say that this is complete and save and exit the form. So this was a speedy version through how to add the 4C data into REDCap. I hope that it was helpful. And as I mentioned, you can get a lot more information if you go online and look at the 4C manual.